So next talk is by Dr. Rehna. She's consultant in Amarda Institute of Medical Science, Kochi. So cracking case of optic neuritis is a topic. Over to you.
Good afternoon, everyone. So, cracking cases of optic neuritis. Optic neuritis, you know that the largest trial which was done, that is the earliest and the largest, was done years back. And that was done in cases of acute optic neuritis. And it came to a conclusion regarding the prognosis, the outcomes, and also the clinical profile of patients with optic neuritis. And it concluded that the visual function after treated or untreated optic neuritis is the same, but it could be hastened with IVMP. But we should note that these patients were all Caucasians, and the clinical profile and the outcome of the patients in our population is a little bit different from that of the West. So, how is optic neuritis in India different from the West? We have more of atypical presentation and a poorer visual prognosis, and more of NMOSD or neuromyelitis optic spectral disorders and other atypical optic neuritis than the West. So optic neuritis itself, you know, it is divided into typical and atypical. Typical is a unilateral subacute loss of vision seen in young females between 20 to 30 years with pain on eye movements, visual acuity better than 660 and has a good visual outcome, and retrobulbar neuritis. So let's go to a typical case. So this is a 31-year-old who presented with decreased vision and pain on eye movements for 3-day duration. The visual acuity in the right eye was 636, left eye 66. There was RAPD and defective color vision. You can see that the disc appears normal. So it's a case of right eye retrobulbar neuritis, which is typical. As ma'am said, here the patient presented with a field showed a centrocecal scotoma. And all cases of clinical isolated syndrome, which includes optic neuritis, should have an MRI of the brain and the orbit with the contrast to be done. One, to look for the cause, if there is any inflammatory lesion in the optic nerve, and also brain to see if there are any demyelinating lesions to find the risk assessment for conversion to MS and other demyelinating conditions. So she had this MRI brain which showed hyperintense lesions in the periventricular area. So she was treated with IVMP as ONTT, followed by oral steroids. Her visual improved. She was referred to neurologist who did the CSF examination. In with patients with MRI findings should be referred to the neurologist, and they look for oligoclonal bands to know the risk assessment of MS, and the patient was treated on disease-modifying therapies as well. So that was a typical optic neuritis. Now we'll go to the next case, which is a 49-year-old lady, which is outside the typical age group, with decreased vision of 2-day duration in the left eye, and visual acuity, hand movements. And the left eye is showing disc edema. So atypicality, age outside, severe vision loss, and disc edema. OCT confirmed increase in peripapillary RNFL thickness. So that's a coronal section of the MRI. Pointer. So if you look at the left eye, centrally, that is the optic nerve, which is showing hyperintense increase in contrast. But I'm going a bit more posteriorly. So it's again increasing. So that is a chiasm. So that area also, the optic nerve is showing enhancement, which means the posterior part is affected and a longer tract is affected, which is in favor of NMO. And that's a spinal cord. You can see that there is hyperintense area here, which is involving almost 3 disc segments, which is also kind of more specific for NMO. So this patient again should be treated with IVMP. CSF studies showed NMO positivity. So diagnosis is left optic neuritis with neuromyelitis optica. So this patient's vision improved, and the long term she was kept on MMF. So what we should know that cases of NMO, sometimes they don't improve with IVMP. In such cases, they should undergo early plasma exchange under the care of neurologists. So it's important to differentiate and diagnose NMO, because patients who are started on interferons will worsen with interferons if it is NMO. So what is NMO? It's a demyelinating disease, more common in Asian population, with a vision loss which is severe and rapid and with a worse visual prognosis if not treated. There is a consensus regarding NMO. I'm not going into the detail, but there are 6 core clinical characteristics, out of which one is optic neuritis. So let's now go to atypical optic neuritis and when to test for NMO or MOG. So if it is age outside the 20 to 45 years, if it's bilateral, painless, vision not improving or worsening on systemic steroid, it recurs once steroids are tapered, or if there is severe diswelling. So consider for any optic neuritis which is not typical. So these are the causes of atypical optic neuritis. There is an entity called chronic relapsing inflammatory optic neuritis, which is steroid dependent and steroid responsive without an underlying cause that we can find. Then other causes, SLE, vaginous, autoimmune, NMO, MOG related, and infections. So I just show you this table, which would help you to differentiate multiple sclerosis, NMO, and MOG related optic neuritis. As I said, multiple sclerosis is a typical optic neuritis which presents in a young adult female. On the other hand, NMO, middle-aged adult female, MOG can affect any age, any sex, and we are recently seeing this more in children. Multiple sclerosis more in Caucasians, NMO more in Asians, and MOG can affect any race. So as a typical optic neuritis, it causes mild to moderate vision loss in multiple sclerosis, but in MOG and NMO, it is severe vision loss at the onset. But there is good recovery with multiple sclerosis and MOG. ONTT says that even without treatment, the cases of typical optic neuritis with MS will improve, isn't it? But NMO and MOG definitely requires treatment, and MOG has a good recovery with IVMP. And typically MS is retrobulbar neuritis, but the other two can present with disc edema. And in the MRI, typical one presents with short enhancement of the optic nerve, NMO longer enhancement with including the optic chiasm, and MOG, it is typically described as a perineural enhancement, that is enhancement outside the optic sheath. So quickly go to the third case. It's a 7-year-old girl, decreased vision, severe vision loss, hand movements with grade 3 RAPD. So there was bilateral disc edema and peripapillary increased thickness, which was confirmed on OCT. So optic neuritis on MRI. The serum and CSF MOG antibody was found to be positive. She was treated with IVMP and she improved. So that's a typical case. Usually it is a pediatric population with disc edema, severe vision loss, and a good response to steroid. And with one episode, usually the neurologists don't start on immunosuppressants. It starts only if it recurs. To summarize, it's a stepwise approach is required for the diagnosis and management of acute episode of optic neuritis. Any atypical neuritis should be thoroughly investigated since the diagnosis and prompt treatment is key to prevent relapses. Contrast MRI for the brain, orbits, and spine are indicated for diagnosing various causes. And it should be noted that NMO-related optic neuritis may actually worsen with infrons, and differentiation should be made before initiation of treatment. A long-term treatment protocol is needed to prevent further attacks and decrease the disability burden. Thank you.